Processes of birth. The birth process affects the physiologic system of the mother and fetus. The most obvious changes of pregnancy and birth occur in the woman's reproductive system, but her other systems also respond in various ways. So let's go over the reproductive system. Normal labor contractions are coordinated, involuntary, and intermittent. The uterus can contract and relax in a coordinated way, just like the heart. When she starts to go into labor, we will see that the contractions will increase in duration, frequency, and intensity. They are also involuntary. A woman cannot tell her body to go into labor or to stop. And they're also intermittent. Labor contractions are intermittent rather than sustained because as the uterus contracts, blood flow goes to that muscle, and therefore blood's being shunted away from the placenta. Then when the uterus relaxes, then blood flow goes back to the placenta and the fetus. Very important note. This is something you should write down. Remember, contractions should have a rest period, being relaxed at least 30 seconds between contractions, and cannot be contracted for longer than 90 seconds. This is as if the fetus was holding its breath for more than 90 seconds and it starts using up its reserve of oxygen. So if we do have contractions coming too fast and we're not getting a 30-second rest, we must intervene, or if we have hypertonus and the uterus will not relax after 90 seconds, we have to do an intervention. And we'll go over that under nursing care. Other changes include, or other parts of the reproductive system include the cycle. The contractions go through a cycle, and we'll go over that on the next slide. Also, the uterine body. The uterine activity during labor is characterized by opposing features. The upper two-thirds of the uterus contracts actively to push the fetus down, and the lower third pulls away to allow dilation and effacement. In those terms, dilation and effacement refers to the cervix. Those are our cervical changes. Effacement, the cervix is approximately 3 centimeters long, so it starts effacing down till it's very thin, and then it dilates or pulls out. Here's the contraction cycle. So as the whole uterus starts to squeeze or contract, it goes up to the peak known as the acme and then comes back down. The duration is when a contraction, from the beginning of a contraction starting to when it ends. So if someone says her contractions are lasting 60 seconds, that's what it means. And frequency is how much from one contraction to the beginning of the next. So if they're saying a contraction is coming every 3 minutes, that's what they mean. And then we have the relaxation in between, when the uterus is relaxed. This is a picture of the uterus, and this is where we have the upper two-thirds. Every time a contraction happens, this part of the uterus is pressing down. And remember, if the baby's head down, it's pressing the head against the cervix, and that also kind of helps the cervix to kind of dilate. And the bottom third pulls out the cervix to help with dilation and effacement. So for cervical dilation, and through the whole phase of labor, they go from 0 to 10, and we can check that by our doing a vag exam. And this is just to give a visual guide of what 1 centimeter is compared to 10 centimeters, which is about the size of a bagel. Here's effacement and dilation. So over a period of time, this will thin out to be very thin. Most of that happens in the latent phase, and then it starts to pull apart to the size of about a bagel, 10 centimeters. Remember, in this area is where the mucus plug is. That's a protectant. Remember what mucus does? It protects us by entrapping bacteria or preventing bacteria from moving up. It's acidic. And so if a woman has a short cervix, then she has less mucus. And a short cervix, of course, is a risk factor for preterm labor. So what are some of our other changes that we have during the birth process? Well, during each uterine contraction, blood flows to the placenta, gradually causing a relative increase in the woman's blood volume. This temporary change during a contraction can raise her blood pressure slightly and slow her pulse rate. Therefore, if you need to be accurate on a baseline of a woman's vital signs, do them between contractions. And in fact, if you see a sudden rise, the first thing you should do is double check that blood pressure between contractions. Also remember that supine hypotension may occur during labor if the woman lies on her back. We went over that in antepartum. So the woman should be encouraged to rest in a position other than the supine position to promote blood return to the heart and therefore enhancing blood flow to the placenta and promote fetal oxygenation. Now, the depth and rate of respirations will increase, especially if she's in pain or anxious, and she may have some hyperventilation, which can cause her to go into respiratory alkalosis. Some of the first signs and symptoms of that would be tingling of her hands and feet, numbness, and maybe some dizziness. So as a nurse, we should be telling her to slow her breathing down. Yes, you can offer her a paper bag maybe, but sometimes they're not readily available on the labor floor. So you can always use an oxygen mask, but not run oxygen through it so that she can rebreathe some of her CO2 or through a cupped hand. Have a cupped hand over her mouth. In the GI, if all the blood flow is going to the uterus during labor in the placenta, it's being shunted away from some of our other organs, including the GI system. So it starts to slow down, and this can cause some nausea and vomiting. Most women are not hungry but may be thirsty, so you can offer ice chips, and based on policy they may allow maybe some clear liquids or juices. Now, with the urinary system, if she's in pain or if she has an epidural, she may not realize she's having a full bladder, and a full bladder can impede the descent of the fetus through the canal. So we want to make sure she empties her bladder regularly, and a lot of hospitals have policies that if they're on an epidural, they get a catheter until they go into labor. And also remember, postpartum, they lose a lot of urine because their hormones are coming down, so they're not retaining a lot of fluid, so they go through almost a diaphoresis in a way in the first 5 days postpartum after delivery. And also remember that their blood, as far as their blood volume has doubled in size, so it's not unusual for them to have a functional murmur, or maybe even an S3 you may pick up on if she has no existing heart disease. However, blood loss during labor, we tend to see about 500 with a vaginal birth. It can be 1 liter if it's a C-section. And also during this phase, they'll have increased clotting factors, and that's because it's meant to be a protection from hemorrhage, but also it increases her risk of developing a venous thrombosis. That is one reason after delivery we get them up as soon as possible after delivery and encourage them to walk so they don't put themselves at risk of developing a deep vein thrombosis. Also, their white blood cell count goes up. The leukocytes count can be 14 to 16 immediately postpartum, but can be as high as 25 during active labor with no evidence of infection. So it's not unusual that you'll do your morning CBC on a postpartum mom, and you'll see that she has an elevated white blood count without no other signs of infection. This is just showing you, we went over this in Intrapartum when we went over the contraction stress test, that how blood flows goes. We have our arteries that dump into these little areas, which are all along. They almost look like cauliflowers from the uterus to the placenta. So it dumps into that, and then there's an exchange that goes into the placenta, which ultimately goes through the umbilical vein. Remember, we have one artery, two veins. Just think of the baby's name as Ava, AVA. And then as it squeezes, there's less blood flow during a contraction. So what happens to the fetus? Responses to labor are most notable in the placental circulation, cardiovascular system, and pulmonary. Cardiovascular system responds to stress with the fetal heart rate, so the fetal heart rate will go up. Remember, the normal range is 110 to 160, and the preterm fetus often has a rate in the higher end of this range. As far as the pulmonary system, the fetal lungs produce fluid to allow normal development of the airways. Lung fluid must be clear to allow normal air breathing after birth. So what happens is labor speeds up the absorption of lung fluid, and that's related to the catecholamines and the prostaglandins that are a result of stress of labor. The catecholamines produced by the fetal adrenal glands in response to the stress of labor appears to contribute to the infant's adaptation. It stimulates cardiac contraction, and breathing quickens the clearance of remaining lung fluid. However, infants born by cesarean birth not preceded by labor are more likely to have transient breathing difficulty, and that's known as transient tachypnea of the newborn, TTN, and we'll review that when we go over the newborn on the last module, Module 4. What are the four components of the birth process? It's called powers, passage, passenger, psyche. And all these have to be, all four of these have to work together in order to have a successful vaginal birth. If one of them is dysfunctional, and we'll go over that when we go over complications, then it can impact the birthing process. Remember powers. During the first stage of labor, onset to full cervical dilation, uterine contractions are the primary force that moves the fetus through the maternal pelvis. Since she does not have conscious control over it, it's a passive process. And then we also have the active process of powers. That is her actually pushing the baby. She'll have that urge to push and bear down as the fetus descends through her vagina and puts pressure on her rectum. The passage consists of the maternal pelvis and soft tissues. The bony pelvis is usually more important to the outcome of labor than the soft tissue. And we have four types of pelvic shapes. It's easy to remember. Gynecoid is the most favorable. Just think of gynecology. Android is not so favorable. Just think of androgens, such as male hormones, androgens, because android is more of a male pelvic shape. And soft tissues refers to the actual vaginal tissues. So what they do is they kind of look at the pelvic outlet, and this is to accommodate the fetal presenting part. And these are our four shapes: gynecoid, anthropoid, android, and platypeloid. And as you can see, this is the most favorable, gynecoid. This is considered more heart-shaped. It has a poor outcome for a vaginal birth. Same with the platypeloid, which is flattened. Makes it difficult for the head and shoulders to fit through on both of these. Now, as far as the passenger, that is the fetus, the membranes, and the placenta. Remember, the skull bones are not fused, and that's to allow them to overlap to mold through the vaginal canal and adapt to the shape of the pelvis. And here are the sutures. This is a fontanelle back here. That's the posterior. The bones of the fetal head involved in the birth process have the two frontal bones on the forehead and the two parietal bones at the crown of the head. Most fetuses enter the pelvis in the cephalic presentation, but we can have several variations. This is just showing you the fetal molding. We also have fetal lie, longitudinal versus transverse, and we have oblique. So longitudinal can be either breech or cephalic, head first, and then transverse is side to side, which is very rare, like 1%. Oblique means it's at a side angle. The attitude is the relationship of the fetal body parts to one another, and a good fetal attitude is flexion, and I'll explain why in a moment. Okay, so here's a full flexion, vertex, so it has an occiput presentation. B, we have a military position, like standing erect in the military. We have brow, and then we have a face presentation. This is a poor flexion. This is partial extension. The passenger, again, can be cephalic, head first, and it can be a subcategory of vertex, military, brow, and face. We can have it breech, which means it's sacrum first, so be frank, full footling. But the one when we were talking side to side, that would be a shoulder presentation, and we can't birth them that way. That would be a C-section. Now I'm going to explain why it's very important on these flexions. This is just reviewing it again, how it fits through the vaginal canal. Look at this, okay? Now, if we have a baby born vertex, this is what's going to fit through the canal. These sutures can overlap, can mold nice, and we only have a 9.5 centimeter diameter fitting through. But when we jumped to the military, which is standing erect there, this is coming down the vaginal canal, that has a diameter of 11 centimeters. So it's going to need a little bit more room to fit, and we can have a little bit of overlapping here. Then if we have what we call the brow presentation, look how much that is, 13.5 centimeters. That is a lot more to accommodate with a vaginal delivery. Of course, we have a little bit of molding here, we could, but not as much as these other two. And last, we have the face presentation. These babies are always born, if they're delivered this way, very bruised, because all the pressure on the cervix, and that is 9.5. But the difference is, even though we dropped a little one side, there is absolutely no way we can have overlapping of sutures here. to help accommodate. Then we have our three deliveries. We have frank, full, and footling. Single footling is 1 foot, and then if two are able to fall through, 2. And looking at this, most would feel, oh, well, the footling is probably the easiest to birth vaginally, but it's not. The one that's the safest is the frank delivery. The reason being is that with this footling, if this baby, if the woman starts to dilate in a face, we have to worry that the feet might fall through before we're able to accommodate the head. That's why. And that is called head entrapment. And especially if they're preterm, because the body's very thin and they have a very large head. Now to discuss positioning of the passenger. You'll notice 3 letters whenever they look at positioning. You have the first letter, it will always be right or left. Your second letter is the presenting part, could be occiput, or if it's a face presentation, M for the chin, S for sacrum for your breech deliveries. And then the part of the pelvis it's in, anterior, posterior, transverse, APT. And I know that sounds very confusing, but we're going to explain it. This is the mom's pelvis, and of course it's labeled according to how it's on within her pelvis. What I mean by that is, remember, when you document your 4 quadrants of the abdomen, it's the mom's left and right, upper and lower that you're documenting. Same with the sacrum for positioning. So here's her back, so that is mom's left posterior side, right posterior, right anterior, left anterior. Transverse means side to side. So what we do is we look at where the presenting part is. So this is a occiput presentation, right? This has a good flexion. The top of the head is there, and it is falling into her right posterior. If we look at here, posterior, anterior, her right posterior pelvis. So the letters will be R-O-P. If the presenting part, which is the middle letter, is in this quadrant, like we see here, the occiput is facing the rear here, it's L-O-P. If it's toward the front here, the presenting part, her right side, R-O-A, L-O-A. So when you consider that's how we put those letters, then all you have to remember is if it's a sacrum, then the buttocks will be in this quadrant, then it would be LSP, RSP, RSA, LSA. And the reason we document these letters is, first of all, to know how the baby's presenting and where to put the fetal monitor, because the monitor has to go on the baby's back. So if I have a documented LOP position, then I know that I'm going to put my monitor in her left lower quadrant to pick up the fetal heart rate. If it's breech with an S, I know I'm going to the upper 2 quadrants based on if it's left or right. So transverse is if it's lying side to side, and you'll just put the monitor in the lower quadrant and then on the left here. And we just went over these. Now here we can see, again with the S, if it's straight on the line and then it's facing towards her left side, it's LST. If it's facing toward the front like here, it's her left anterior, but it's the sacrum, so it's LSA, LSP. And it's the same with the mentum, which is the chin, if it's a face presentation. Now, the last of the P's is psyche. She has to have a frame of mind for delivery, and what can impact her psyche includes sometimes culture. A woman's culture affects her views of birth and the practices surrounding it. And it also shapes the values that people hold, their expectations of the birthing experience, and their responses to the birth. We also have birthing experiences. Families describe the birth of their children as they describe other important events in their life. And for example, with birthing experience and psyche, if you had a woman who had a stillbirth and now she's back into labor again, she may have her psyche may affect her. For instance, if she can't hear the fetal heart rate, or she may be very anxious while she's pushing, hoping that something didn't happen to her baby. And then there's technology. The goal of maternity care is to protect the health of the mother and the fetus, and technology helps caregivers identify problems and intervene. So that can also affect the psyche. And again, as I said, the interrelationship of the 4 components, they must work together in order to have a successful vaginal delivery. So what are our theories of onset? Despite research, the exact mechanism that initiates labor remains unknown. Labor normally starts when the fetus is mature enough to adjust easily to extrauterine life. And this can go from 38 to 42 weeks. And natural labor begins when forces favor continuation of pregnancy are offset by forces favoring its end. So some of our theories include changes in the ratio of maternal estrogen to progesterone, so that estrogen levels are higher than progesterone levels. Progesterone promotes smooth muscle relaxation during most of pregnancy. Then we have prostaglandins. They're produced by the decidua, and that's part of the inflammatory process, the release of prostaglandins. Prostaglandins are secreted from the lower area of the fetal membranes during labor and may reflect the inflammation caused by contact with microorganisms from the woman's vagina. And that can stimulate labor to have. Now, remember, by me saying that with microorganisms, remember then other microorganisms such as STDs, which cause an inflammatory process, can be a cause of premature labor. Almost under that same kind of theory. Oxytocin receptors in the uterus increase markedly as labor begins. And so if those receptors are open, then labor is more likely to happen. And what's interesting about that is that's why if we have someone who's carrying a stillborn baby, prematurely, we can't use oxytocin to stimulate labor to deliver the stillborn fetus because there's not many receptors open. That's why we use something such as Cytotec to stimulate opening of the cervix. And that's also, if her labor's not ready for birthing, we have to soften her cervix to allow more receptors to open. And that way we're not using a whole lot of oxytocin to try to get some contractions out of the mother. And I go over that in labor pharmacology. So what are some of our early signs that she may be going into labor? Well, first of all, when we went over contractions, they get stronger as she goes through labor. Well, Braxton Hicks, which is false labor, gets stronger and stronger, and that's why a lot of women show up thinking they're in labor, but it's actually false labor. So if someone's Braxton Hicks starts getting stronger and stronger, she may drop the term we use is lightning. And if it's a first-time pregnancy, she may drop 4 weeks before she's due. And if she's had children before or multiple pregnancies, they may not light until right when they go into labor. If we have a cervical ripening or bloody show, as full term nears, the cervix softens because of the effects of the hormones, and the ripening allows the cervix to yield more easily to the forces of labor contractions. As the fetus head descends with lightning, it puts pressure on the cervix, starting effacement and dilation. She may have a bloody show, which is a mixture of the thick mucus and pink or dark brown blood. And that may begin several days to a few weeks before the onset of labor, especially in the nulliparous woman. It may not begin till labor starts. So if she's been pregnant before and through a laboring process, she may walk around 2 to 3 centimeters dilated before she actually starts labor, compared to the nulliparous, the person who has never delivered before. We can also have an energy spurt. We call that nesting, like when birds build nests before they lay eggs. And we may see a small weight loss. She's holding a lot of water from all that estrogen and progesterone. But near pregnancy, remember, those levels start waning off. So she may lose a little bit of water, resulting in weight loss. Very important is understanding true versus false labor. And one of the main things is contractions, because they come in thinking they're in labor, and we have to teach them to understand the difference, because sometimes they get very agitated when you say, well, we're discharging you because this is not true labor. The best measure of true labor is progressive dilation and effacement. So if they come in and their contractions are really strong, and we want to make sure, is this false labor or true? You do a vag exam, and then 3 hours later you recheck, and if there's no more change, then we know that it's false labor. False labor begin and remain irregular. True contractions begin irregularly but become regular and predictable. In false labor, it's first felt in the abdomen, and with true contractions, it's felt first in the lower back and sweeps around the abdomen in a wave. And the biggest criteria is, especially if women call to find out, should I come, am I in labor, is we tell them, well, are they disappearing if you walk? Change your activity. If you were walking when they come on, rest. And are they starting to slow down or go away? Then it's probably false. However, true labors will continue no matter what her activity is. And just to go back about false versus true contractions with preterm labor, that's how we also assess if a woman may be in preterm labor. If she calls and says, well, I think I'm having contractions, it's like, well, rest, drink some fluids, rest, and if they don't disappear, you need to come in. Because changing the activity did not change the contraction pattern. They do not increase in duration, frequency, or intensity, and they do not achieve cervical dilation. That is our most important criteria. So what are the mechanisms of labor? That is how the fetus moves down the canal. The head becomes engaged, then it flexes, it rotates, extends its head, and then has an external rotation to help get the shoulder through, and then we have expulsion. And we see it right here, how it goes, has a slight rotation to fit around the pelvic symphysis pubis, extends a little, rotates again slightly to be able to get the shoulder out. Okay. And this, we can see it in the video. Engagement. See flexion, then extension, then another rotation, and then expulsion. Okay. Now, very important, students miss this in questions all the time. Remember, there are 4 stages of labor, but there's only 3 phases there are only 3 phases within the first stage. Okay, so we have the latent phase, which is 0 through 3, and that phase can last a long time. It could be days or weeks. Let me get back to that. The active phase, which is 4 to 7, and then part of the active phases we have, it's called the transition. That would be 8 to 10. Now, the purpose of latent phase mostly is to dilate or actually efface out the cervix. The active phase focuses more on dilation. So in the active phase, we expect that the first time to pregnancy will dilate approximately 1.2 centimeters an hour, where the multipara we expect a rate hopefully of 1.5 centimeters an hour. If we don't get that, usually we'll try to augment the labor. If the labor starts slowing down and she's not dilating, they may give a little Pitocin, maybe do an amniotomy and break the bag. And the Friedman curve is just a curve, which I'll show you in a second, that we look of anticipating how long labor will be. And the reason we don't want her to stagnate or slow down is because the uterus is working really hard through labor. And if we extend out how long she goes in labor, it increases her risk of a postpartum hemorrhage, because that uterus is tired and it's going to have to contract some more after delivering in order to stop the bleeding and also shrink down in size. That's another reason why, we only want to use Pitocin when she has lots of receptors opened, and not have to use a whole lot of it, and because Pitocin makes those contractions really strong. And use it just enough to stimulate labor until her body can take over itself. Transition, contractions are a lot stronger during that time. That is where we go from 8 to 10 centimeters. Okay. So here's an idea when I talk about the Friedman curves. We expect maybe over 8 hours, and it can be even longer than that, she slowly does a lot of effacement, and then some of the dilation. Then we pick it up actively through the active phase, and then we go into transition and then delivery. Progress of labor, usually average will be 12 to 14 for a first baby. If it's a subsequent baby, maybe 6 to 8. It can vary. Precipitous labor is the term that we use for a baby that comes too fast. That means within a couple hours. And we'll go over that when we do nursing care. And remember these terms: effacement, dilation, descent. We cannot just dilate and efface in order to deliver a baby. The baby's got to be able to move down the canal, and descent refers to stations. The fetus head descends through the birth canal. It's defined relative to the ischial spines. So the ischial spines is the smallest diameter, and when the head reaches the top of the head, it's considered fully engaged. That's very important. The reason being is once the head is engaged, we don't have to worry about maybe the cord slipping through and having a prolapse cord. And a lot of procedures that we don't do unless we know the head's engaged, such as maybe breaking the water. Remember, the top is negative, the bottom is positive, so the closer she gets towards the baby crowning, we see these positive numbers go up. Okay, we'll just go on. Second stage of labor. For first time, this is pushing. So remember, there was 3 phases within the first stage. Going from 0 to 10 centimeters, we got latent active transition. The second stage of labor is how long it takes a woman to push. And the contractions are really strong. So we're dealing with her having the ability to push, having the strength, lasting through it, but also the stress of those long contractions on the fetal oxygenation. So with nulliparous, 30 minutes to 3 hours, multiparous, 5 minutes to 30 minutes. The third stage is delivery of the placenta. We expect the placenta to deliver naturally within 30 minutes. Now, a lot of times it comes a lot sooner, and if it's not, she's at risk for hemorrhage for that retained placenta, and usually the healthcare provider will manually remove the placenta. And think about that. He's putting a hand and removing a placenta. There's an increased risk of a infection, and also he may leave a part of it in there, so we have to check the placenta when it delivers. And it's more likely to have a retained fragment if we're manually trying to remove it. We still check it whether it comes naturally or it's manually removed. We document if it's a Duncan versus Schultz, and I'll show that in a minute. What are signs that the placenta is coming? Well, first there's increased bleeding because it's starting to separate. The length of the cord starts, we see lengthening of it. The uterus rises up into like a globe, and then the uterus enlarges as it approaches the umbilicus, and then we see a separation. This is the side that the fetus is against internally. See the cord there? So it comes inside out, and this is dirty Duncan. This is the side that was against the uterus. So either or is the presentation. Usually we see the Schultz. What is the fourth stage of labor? Well, that is the first 4 hours. We will see that the uterus starts to shrink down. We expect it to be at the level of the umbilicus. We also assess the lochia, see if there's a lot of clots there. She'll go through chills because of the diaphoresis, the change in hormones. That's not unusual. And the closer she is to having just delivered, the increased risk of her having a postpartum hemorrhage. That's why we watch them right after delivery. We don't just send them off to postpartum, or we don't increase how many patients we're responsible for until we know that she's stable in this fourth stage. And very important during this stage is we document bonding, that if she's going to breastfeed, she breastfeeds, she holds the baby, we do skin to skin. And we see that there may be discomfort during the fourth stage resulting from birth trauma or after pain. She may have to have maybe, if she had an episiotomy, that will have to be sutured. She may also be very exhausted. The total duration of labor is significantly different in every woman who's never given birth and to those who have previously given birth. Remember, the parous woman usually delivers more quickly than the nulliparous woman. Make sure you understand all those terms. Look at the beginning of your chapter and review definitions if you're not retaining them. Okay, and in review,
delivery through new mommyhood. In the weeks before birth, your body slows down production of the hormone progesterone while increasing production of other hormones, including prostaglandins, which soften the cervix, and oxytocin, which triggers the uterine muscles to contract. True labor contractions are rhythmic and painful and grow consistently stronger. As the long vertical muscle bands of the uterus tighten, they pull the cervix open. The strong muscles at the top of the uterus push down and release, guiding your baby toward the cervix. The mucus plug, a collection of thickened cervical mucus that sealed your cervix shut for 9 months, may be expelled days before or in the midst of labor. When the amniotic sac ruptures, your water has broken. It can feel like a trickle or a gush of fluid. Your cervix will begin opening and thinning, known as dilation and effacement. Once you reach about 4 centimeters, your body will move into active labor. In active labor, contractions become stronger and closer together. At 8 centimeters, you enter what many consider the most painful part of labor, transition. By 10 centimeters, you're fully dilated and may feel the urge to push. This is your signal that the second stage of labor has begun. Your baby will move down with each contraction. The 3 separate soft bones of his head will temporarily overlap so he can pass through the snug birth canal. Your baby's scalp will come into view. When the widest part of his head is visible, your baby is crowning. With several more pushes, your baby's face, shoulders, and body will emerge. In the third and final stage of labor, your placenta detaches and is expelled. With your baby's first breath, the incredible journey of birth is complete.
And last, I just want to review stations. So just give me a moment. Now you can see the ischial spines. And see, these numbers are negative, so we use the term floating if they're above, because if she's floating and her water breaks, then we're concerned about checking the fetal heart rate, making sure we don't have a prolapsed cord. 0 meaning engaged, and then as it's delivering, it goes to +3 to start crowning. And that's it for this lecture.